My name is Jason Schillerstrom, and I'm an assistant professor of psychiatry at the University of Texas Health Science Center at San Antonio. One of the docs on faculty here. I work in the Division of Aging and Geriatrics. And for probably a key part of my job is doing decision-making capacity evaluations for clients and their families. And then I also work very closely with Adult Protective Services. Once a week I go out with Adult Protective Services and do decision-making capacity evaluations for their clients. And so today we're going to talk about decisional assessments. We'll initially describe what is incapacity, and there is a legal definition for incapacity. We'll talk about the challenge of doing functional status assessments when we're assessing for capacity. We'll talk about the relationship between cognition and capacity, and then we'll look at the consequences of incapacity. What can we do if someone doesn't have decisional capacity? And so, beginning, we'll talk about what is decision-making capacity. So commonly, I'll get questions like, is it safe for my mother to live at home? Can she live by herself? Can Dad still drive? These are common questions that I get asked in my geriatric psychiatry clinic, and these are tough questions to answer. For incapacity, the state there's a legal definition of incapacity in the state of Texas, and the legal definition is because of a physical or mental condition a person is unable to provide food, clothing, or shelter, attend to physical needs, or manage financial affairs. So this is the legal definition of incapacity. So a person in Texas would be considered to be have decisional incapacity if, because of a physical or mental condition, they are unable to provide food, clothing, shelter, attend to their physical needs, or manage their finances. And so what's important in the definition are the verbs. And so it's provide, attend, manage. And so sometimes people will say, well, they have food. Okay, this person has food, and so maybe they don't have decisional incapacity. Maybe they're okay. Or they'll say, well, neighbors bring them food. And that happens quite commonly, where neighbors will be bringing a loved one food or clothing. And then it's implied within the definition that these are safe. So they have to not only provide food, but they have to provide safe food. Just as with shelter, they have to provide safe shelter. So we wouldn't say that someone's able to provide shelter because they can find a bridge to hover under, right? Or they're able to provide shelter because they do have a roof over their head. Never mind that the water isn't on, the electricity isn't on, the sewage isn't working. It's either rat or cat infested, and so it has to be safe shelter, safe food, safe clothing. And with clothing, the example would be, it's not do they have clothes, it's are their clothes safe. So they can't just be dressed in rags, for example. And the same with attend to physical needs. And this has to do with, can they attend to their own medical care? Can they take their medications appropriately? Can they follow doctor's instructions? So when the doctor says, okay, you have diabetes, and you need to check your blood sugar before every meal and once before bed, are they able to manipulate the glucometer, and are they able to check their in this case, their blood sugars as suggested by the physician. And then finally, again, managing finances. It's not, do they have money in a bank account? It's, are they really managing their money? Are they paying the bills? Do they know how much money's coming in? Do they know how much money's going out? And so the key is real in the definition is really the verbs. And so that is the definition of being decisionally incapacitated. If because of a physical or mental condition, they're unable to provide these things, attend to physical needs, or manage finances. For physical conditions, in my clinic, because I'm a geriatric psychiatrist, we're always looking at the mental condition. And in general, what we're trying to decide is, do they have incapacity because of a dementia or even because of a depression? And so in my setting as a geriatric psychiatrist, I'm trying to decide, are they not attending to their needs because of a mental condition? And in almost every case, it's because of a dementia or a mood disorder. Sometimes I'll get cases where the person might have schizophrenia. And so they're not going outside of the house to go buy food, for example, because they're afraid that someone is stalking them, and they're not getting their food because they have these profound paranoias. So that might be an example of a non-dementia case. But in general, I'm trying to when I do these capacity assessments, is it because of dementia? And so, so that's the definition. So then that brings us down to how do we determine if they're able to provide food, clothing, shelter, attend to physical needs, or manage their finances? And so how do we determine this? And this brings us to the idea of doing functional assessments. And so you can ask yourself, what might be the best way to assess functional abilities? And there's 4 general ways that functional abilities are assessed. So the first is self-report. The first we'll talk about is self-report. So one way to assess functional status is to ask the person what they're able to do. And you can imagine how this might go. So we might be asking a 75-year-old man with moderate Alzheimer's disease, can you drive? And he might say, yes, I can. And so, and we might do it for driving. Can you manage your own medications? Yes, I can. Can you bathe and dress and do all this stuff for yourself? Yes, yes, yes. Or he might say, actually I can't, whatever it is. I can't, my daughter helps me with my medications. My daughter puts the pills in the pill box for me. So they don't always over-report, but a common problem with self-reported functional abilities is the idea that they do over-report their abilities. So self-report is nonetheless one way that we'll try and assess functional status. The other way we'll try to assess it is with proxy reports or caregiver reports. And so we won't ask, in this example, the 75-year-old man with Alzheimer's disease, if he can drive. We'll ask his daughter. And so we might ask his daughter, can your dad safely drive a car? And then we'll see what her answer is, and it might be yes or it might be no. And we'll do this for each of the different functional impairments. The challenge with proxy reports is the idea of caregiver burden. And so what commonly happens with caregiver burden is that the person reporting the disability will say, will get statements like, they can't do anything. I have to do everything. I have to bathe him, dress him, I have to drive him, I have to do it all. And so because of caregiver burden issues, where the caregiver develops this depressive state, they might over-report the true disability of the client. Perhaps the client really can dress himself, or he can cook a meal, who knows what it is, but because the daughter is doing so much, or the son is doing so much, or whoever the caregiver is doing so much, we'll get these comments of, I have to do it all. So proxy reports are one way. The other way we will try and assess functional status is with performance-based measures. And so a performance-based measure might be, I might give one of my patients a phone book and put them in front of a phone. And I might say, okay, I want you to look up the number for, I want you to use this phone number to tell me give me a number that you could call if you wanted to open a checking account for your money. Using this phone book, show me a number that you could call if you wanted to open a checking account for your money. And I'll just watch them use the phone book, and they need to, be able to flip to either the white pages or the yellow pages and find a number of a bank that they could call if they wanted to open up a checking account for their money. Or I might present them with a pretend bill, and I might say, okay, pretend that this is a bill that you owe, and I might give them a pretend check, and I'll say, okay, I want you to pretend you owe this bill. Show me how you would write out a check to pay this bill. And so these are performance-based functional assessments. And so the advantage to performance-based functional assessments is that they're much more objective. You can actually see what they have the ability to do. The disadvantage of performance-based assessments is that you're assessing what your patient can do, not what they actually do. So they might be able to show you how they can balance a checkbook, but in reality, they have all these bills that are past due, and their electricity's been shut off, and their water's been shut off, and although they can show you how to do it, they're not actually doing it. Okay? And so that would be performance-based. And then the final way is just direct observation. So you can just go into someone's home and watch them and just see what they do. The problem with this, of course, is that you'd have to probably be there a week, and we just don't have that luxury. So when we're doing these decision-making capacity assessments, when we're trying to determine is a person able to provide food, clothing, and shelter, are they able to manage their financial affairs, are they able to attend to their physical needs, we use all these different ways to gauge their functional status. And so the first step is, when we're doing decisional capacity assessments, is to determine what is the person able to do, what are their functional abilities. Next, what we'll do is we'll do cognitive assessments. And so, again, what we're trying to establish is that a person isn't attending to their medical needs, financial needs, or just basic survival needs because of a mental condition. And usually the mental condition that I, as a geriatric psychiatrist, am confronted with is dementia. And so with dementia, we're trying to decide, is it because of cognitive impairments that they're not attending to their basic needs? And so there's things that I'll hear all the time, from families and other care providers and social workers. Things I'll hear all the time are, well, he knows what the date is. Okay? He knows what the date is, so he must know how to make decisions. So he knew the date. Or I'll hear, well, he knows who the president is. Okay? So he knows who the president is. He knows the date. He seems to be okay is another thing I'll hear. His house looked clean is another thing I'll hear. So what we have to decide is, what cognitions then are associated with decision-making capacity. Is knowing the date a good indicator of being able to make decisions? Is knowing who the president is a good indicator of being able to make decisions? And as it turns out, not so much. There's been lots of times I didn't know the date, and yet I think I can make pretty good decisions. My wife might not agree, but nonetheless, our question is what cognitions then predict decision-making capacity? And so maybe memory predicts decisional capacity. You can imagine how, memory might be important in decision making. But there's lots of cognitions out there. Memory is a cognition, attention is a cognition, concentration. What else? You could say that math is a cognition, processing speed. So there's all sorts of cognitions, but there's another one called executive function. And so executive function is the cognition that consistently predicts decision-making capacity evaluations in multivariable models. And so memory is important, and I'm not saying that these others aren't important. They're all important. But memory, what we find is that memory predicts decisional capacity in people with Alzheimer's disease, and it predicts it very well. However, while Alzheimer's disease might be the most common dementia, it's certainly not the only dementia. And so there's lots of ways that a person can develop cognitive impairments beyond Alzheimer's disease. So for example, if they have strokes, then that can cause cognitive impairments. If they have vitamin deficiencies, if their thyroid levels are out of whack, if they have other metabolic disturbances, if they are heavy drinkers. So there's lots of ways to become demented beyond Alzheimer's disease. So memory predicts decisional capacity in people with Alzheimer's disease, but executive function consistently predicts decisional capacity in people with any cognitive disorder. It's not specific to just Alzheimer's disease. And so there's different methods that I'll use to test executive function. So executive function is your ability to plan, organize, sequence, monitor, and inhibit complex behaviors. And so what we'll do, you can kind of think of it as problem solving. And so different ways that I will assess executive function are, I might ask them to, I'm going to say some numbers and letters for you like this. 1A, 2B, 3, what would come next? And they should say C. And then I'll say, okay, now I want you to start from the number 1 and go till I say stop. And an executively impaired person might do something like 1A, 1B, 1C, or they might just say 1, 2, 3, 4, or they might say 1A, B, C, D. They can't alternate between sets. And so they could count from 1 to 100 without any problem. They can count, or they can say their letters from A to Z without any problem, but they can't alternate between sets. That's a novel problem-solving task that requires set shifting, and they'll fail that. And so that might be a way that we cognitively assess for executive function. Another way might be to say, I'm going to give you a letter, and I want you to name as many different things as you can think of that start with that letter. For example, if I say P, you can say people, place, pot, plant, and so forth. Do you have any questions? The letter is A, go. And I just write down how many different words can they say that start with the letter A. If they can't say at least 10 words in a minute, then I know that there's a problem. And when I do these assessments, for example, for one of these tasks, it's how many words can you say that start with the letter A. I'm even pretty lenient with them. And so, for example, if they were to say apple, applesauce, apple pie, I'll count those as different words even. But eventually, what commonly happens is that they'll say apple, applesauce, apple pie, cherry pie, pecan pie, and so they'll just get off track. And so that would be a verbal fluency task. So what consistently predicts decisional capacity in regardless of diagnosis is executive function. And these are examples of executive tasks that I'll use in my clinic. There are others as well. We'll have them, for example, draw pictures of clocks, and they have to draw the clock, and they have to set the numbers right. And so there's clock drawing tasks. What else? There's different what we call Luria motor movement tasks. So, for example, I'll ask a patient to do this. I'll say, "Can you do this?" And so I'll just kind of alternate between my fist and my hand. And people with executive function impairments, a lot of times I'll get this response. They'll start doing this. And I'll say, "Well, no, that's not exactly what I'm doing." And so then I'll model for them again. And they just can't do that. They just can't alternate between the sets. Similarly, I might say, "Can you do this?" And I'll just kind of alternate between, palm, fist, side of my hand. I'll say, "Can you do this?" And so I'll have them do that as well. So there's lots of different ways to assess for executive function. In general, these are problem-solving tasks where they're having to break a routine. And again, executive function consistently predicts decisional capacity. If a person if a person fails these executive measures, in general, not every time, every situation is different. If they fail the executive tasks, in general, we usually find that they don't have capacity. If they pass them, there's still work to be done. But in general, if they pass them, they're fine. So again, what I would suggest to you is that if you are assessing cognition to help you with your decisional capacity assessment, it doesn't do much good to ask them the date, the day of the week, the month. Memory tests generally aren't very helpful. Having them spell world forwards and backwards isn't very helpful. What is helpful are these executive tasks. So I would encourage you to incorporate that into your decisional capacity assessments. And so if a person isn't meeting if a person isn't able to provide food, clothing, shelter, if they're not able to manage their money, or if they're not able to attend to their physical needs, and we believe that it's because of a mental condition, in this case dementia, then they don't have decision-making capacity. And so a lot of times when patients come to my clinic, we're trying to assess their functional status, we're assessing their cognitive status, and then through these assessments we're able to tell family, that, no, your father actually isn't safe to drive, or, your mom probably shouldn't be making her own meals, or it really just isn't safe for them to be at home. And so it's through the interview and the cognitive assessments that they do. For adult protective services cases, the APS cases that I see, when I go out with adult protective services for these decisional capacity assessments, they need to know, does the person have capacity? And if the answer to that question is no, then the question that they need to know the answer to next is, are things so bad that we need to do a removal to usually a nursing home or another medical facility? Do we need to remove this person from their home today? And so for us to do a removal to a nursing care facility, for example, we have to demonstrate that the person, if they were to stay in their current environment, that there's an imminent risk, that there's a danger. And so this summer I've done lots of removals where you walk into the home and the electricity's been shut off and they don't have air conditioning and the temperature inside the home is 95 plus degrees and there is an imminent risk of dying from heat exhaustion. And so then we do the removals. We'll also have the patients who you just walk into their homes and they're just living in this squalorous setting with 1,000 cats and all the animal feces and the dead animals and the stuff, and it's just their environments are so unsafe, structurally unsound, that there is an imminent risk to that loved one being in this environment. And then I will make the recommendation to Adult Protective Services that they do a removal to that they place the person in a setting able to provide 24-hour supervision and a safe level of care. And so those are the consequences. And then guardianship will be pursued thereafter if it's appropriate. And so they're asking me, does the person need a guardian? And I give a medical recommendation on that. So that's how we do the decision-making capacity evaluations. The learning point, I think, if there's one thing I want you to learn, it's that in Western culture, if a person is highly alert and they're highly verbal, then our culture dictates that they have capacity. And this goes back millennia, right? This goes back to the Greeks, right? If they're alert and verbal, they have capacity. But that just isn't the case. It would be nice if that was the case, but it's just not the case. And we really do have to do the functional assessments and the cognitive assessments to determine if they have decision-making capacity. It's about more than just being alert and verbal. Okay? All right. I'm happy to answer any questions or not. So thank you for your attention.
How does it help you in your treatment of a patient or a resident to know what kind of dementia he or she might have?
Yeah, how does it, so the question is, there's lots of different types of dementia, and how might that type of dementia influence treatment? And so there are medications that are FDA indicated for dementia, for Alzheimer's disease, and also for Lewy body. And so if we know what type of dementia they have, then we can predict the response from the treatment. And so, if a person has Alzheimer's disease and we put them on an acetylcholinesterase inhibitor, I'm able to tell families what that response will be. And it's very predictable. However, if I don't know what type of dementia they have and we're just kind of winging it and we're using random therapies, then the results are less predictable, and we just it makes it harder for families to appreciate the response. And in some cases, it can be dangerous. So, for example, there have been studies that have shown that that patients with vascular dementia, for example, have increased cardiac mortality if they're treated with acetylcholinesterase inhibitors. And so just because someone has memory impairments doesn't mean we should throw donepezil or Aricept or whatever at them. In fact, we might be doing more harm than good. And so acetylcholinesterase inhibitors would be a classic example with vascular dementia. So it really does help. The same is true with, if someone has Lewy body dementia and they have visual hallucinations, then giving them an antipsychotic might actually make them way more worse than not treating them at all with an antipsychotic. Whereas giving a person with vascular dementia an antipsychotic might actually really help. And so that's how knowing the diagnosis is helpful. Any other questions? No? Okay. Thank you for your attention.